Does everybody see that okay?
Yes, thank you.
Excellent. Thank you. Whenever you're ready, Robin.
Okay. I'm just seeing which case was up.
This one is, now I can't even see the top. 2460.
All right, this young lady, 29 years old, started using drugs at around the age of 17 or 18. So she thinks that she contracted hepatitis C just a couple of years ago. She's been clean for 7 months. She has a really good support system right now, and I think she finally has her life together. She's working at one of the local restaurants as a server. Her brother and her mother has her good support system. She did have a boyfriend, but I think they broke up recently. So her medications, I have her on vitamin D. She's on citalopram, multivitamin. She has trazodone for sleep, and she's on birth control. I did change her birth control recently to Micronor, so it's a progestin only medication. Relatively healthy as far as the rest of her labs. Her APRI score was only 0.36. Her child Turco-Pu class 5 male score was only 6. She's HIV negative. Her genotype is 1A. Her viral load was 50,800. And she's an F0 for fibrosis. So I feel like probably an easy treatment with her would be the Maverick times 8 weeks. Any different suggestions?
Thank you so much. Does anybody have any clarifying questions for Robin before we go into the recommendations portion?
Robin, just a quick question. When you mentioned that in the hepatitis B immunity notes that her patient has reactive antibody test, is that of the surface antibody?
I think that was her service. I don't think she was core positive. That's what you're asking. I'll have to look her back up right quick.
Yeah, that's all. That's all. I was wondering which antibody.
Yeah, I think hers was her surface antibodies. It wasn't, her core was not positive. So if I can look to make sure.
It was her choice of birth control switching to the progestin only in anticipation of
Yeah, I
treating?
switched that. I had her in for a visit the other day, and I switched that because she's not currently in a relationship, but she is talking to someone, and so I figured we'd just go ahead and switch that just in case.
Yeah,
So
good call.
Yeah, she's not gonna. She liked the other one better, but we're just gonna do that for now. Yeah, so her core was negative, so yeah. So surface antibody was reactive. So are you in agreement with Maverick times 8 weeks?
100% Maverick, genotype 1A, she's Medicaid. Yeah, so that's your options, Maverick, Repclusa. And no reason not to give her the shorter course. Agree with you 100%. Maverick sounds good. No HCC screening. She's a cure and done. So life will be good. But I commend you for trying to get her treated now. She's obviously childbearing age, and we don't talk enough about mother to child transmission. There may even be a case this presentation session, if I'm not mistaken. Maybe one of the cases had it. But anyway, that's eliminating 4 to 7% chance of passing this on to a little one. So good stuff. Love it. Yeah, real bummer we can't do anything to prevent mother to child transmission in Hep C. We've got amazing interventions for Hep B, amazing interventions for HIV, but still nothing for hepatitis C. So the best thing we can do is treat them.
All right, it seems like I don't know if it was on this conference call or another one or this video, but it seems like in the past we talked about how often we test babies after their mom has been positive. And I just have another patient. I was just curious, if the baby's initially tested when they're born and they're negative, what is the next follow-up recommended for the baby? I know they have
I don't know the answer to it. I never do that end, but it's the punchline is you got to check. It depends what you're checking. If you're checking RNA versus the antibody, because the antibody can obviously be transplacental crossed for a long time. And I want to say it's 18 months it can persist or something like that.
Okay.
And but yeah, I'm not up to date on pediatric screening. I apologize.
Oh, that's okay.
18 months sounds right to me from what I've learned on echo in the past. Checking. And I had two questions. What was the change in birth control in anticipation of treating her Hep C? I think I don't know about that.
Yeah.
Oh,
Yes, because
okay.
of estrogen.
Yeah, so the Mavorite, the protease inhibitor based regimens, and I'm trying to look and see if Rachel's on. Yeah, Rachel's on. Hey, Rachel, you want to do it? You'll do it better than me.
Sure. Yeah, so the Mavorite, it was actually something that was discovered originally with Vicura, which we don't really use anymore, but it's the same interaction with Mavorite. Mechanistically, we don't really know exactly what it is, but what they saw in the trials when they were evaluating these drugs is that patients that were taking the Vicura and the Mavorite concomitantly with ethinyl estradiol containing birth controls, their ALTs skyrocketed like 3 to 5 times upper limit of normal. And then when they stopped, their ALT normalized. So they're not recommended to be given together. And unfortunately, pretty much all of the combined hormonal contraceptives, that estrogen component is that ethinyl estradiol. So yeah, great option to change to a progestin only for her. Love to see it.
Thank you. And my only other question, and maybe you addressed this, Robin, but it looked like her vitamin D was low. Is she on replacement?
Yes, yes.
Okay,
She's on
thanks.
vitamin D.
Great. Thank you so much for those great questions and commentary. We'll go ahead to the second one. Just give me one moment, please. All right, there it is, Robin. This is your second case, 2502.
Okay. This fella, 55-year-old male, he is a patient at the Southern Highlands, one of the substance abuse programs here. He does smoke. He smokes marijuana as well several times a week. I don't think he has intention of stopping that. Several allergies. When he came in for an office appointment, he complained of some right upper quadrant pain. And so I had ordered an ultrasound, which showed some polyps in his gallbladder. And we have referred him to a surgeon to take care of that. Anxiety and depression. His last IV drug use was 2017. He did have a blood transfusion a while back, but he's not sure exactly when that was. I really don't know what it was for either. I really can't remember what his story was there. So he has some COPD, hypertension, headaches, and his medications. I don't think there's any problems with his medications as far as interactions with potential medications. So he is on the vitamin D replacement as well. He's on medicines for hypertension and the meclizine. I think that was just temporary. He's probably off that meclizine by now. He's been referred to ENT for some dizziness. He's immune to Hep A and B. And again, I don't think his core was positive, but I can double check that if needed. His labs were mostly okay. Creatinine 1.13. His liver enzymes were, pretty elevated, 235 and 285. His child Turco-Q score was 5. His male score was 8. His APRI's 2.75. His viral load 8,950,000, and he is at F1, F2 for his fibrosis score. I feel like probably again Mavorite would be the best option for him as well.
Thank you so much, Robin, again. Does anybody have any questions for Robin before I go into the recommendations? All right, if not, anybody can raise hand or unmute.
Should I talk?
Absolutely.
All right. Robin, great job. Good presentation. Medicaid patient, 55. He's got that cardiovascular risk background, so you're going to be reducing this inflammatory stimulus in him will be good for him in general, especially given that he's a hypertensive 55-year-old. His labs are a little scary, but in particular, the APRI looks really negative. It's, I should say it looks very pessimistic, 2.75, probably largely reflects that massive AST elevation at like 10 times normal or whatever that is. I can't do the math in my head, but it's very high. And, evidencing that he's got a major activity level going on, a lot of inflammation. It's interesting because, thank you for putting the A score on his serum fibrosis biomarkers. We a lot of times only pay attention to the F score, but you put the A score there. And, that really, remember the poor man's activity score is just the transaminases, which are really reflected. Thankfully, they're concordant on the serum biomarkers as well as the traditional transaminase evaluation. So, what I would do with this guy is, you're genotype 2, so you only have 2 options as your first line therapy, Epclusa or Mavorite. There's no drug-drug interactions of concern that I see. So I would go with whichever. He's also not a decompensated person. It doesn't even have, I don't think he actually has cirrhosis. I think his APRI is falsely pessimistic just based upon markedly elevated transaminases. What I would do with this guy is recheck his transaminases, obviously with time as you're treating him, and if they don't normalize and your APRI stays high, then you might be stuck doing chronic HCC screening, but I doubt he actually has cirrhosis. His platelet count's just too normal. I would just follow up on that APRI and actually even follow up on his serum biomarkers as well, probably after treatment, a couple months after treatment, to make sure everything's rock solid. His ferritin probably represents just, he doesn't drink still, right? No, he doesn't drink anymore. But it's probably just the hepatitis, but I'd follow that too. It's very elevated, 1200. I don't see on here that we have a percent iron saturation or percent transferrin sat.
I mean, look, if I've got it on his labs.
Yeah, T set.
Sometimes I put in order sets and then something happens and they don't get done at the lab. And I
Right.
don't know why.
Yeah. But that would be one of these things where when you are evaluating this guy as to whether or not you need to work him up for secondary etiologies besides the hepatitis, like hemochromatosis, the percent sat can be helpful, but all that I would think can take a back seat to just treating his genotype 2 hep C and see what happens. By the way, is his surgeon gonna take out his gallbladder? Do we know?
I don't know just yet. He had to cancel an appointment because somebody had COVID or something. So now that's been rescheduled.
Okay, there's a funny, we poo-poo liver biopsies because there's morbidity, obviously, with doing them. But sometimes when a surgeon's in there, they don't mind getting a sample. There's disparate information in this guy. You have, biomarkers that say he's okay, but you've got an APRI that looks terrible. And you're literally going to be having a surgeon in there with his, equipment right next to the liver. And they are not opposed. Surgeons are often not opposed to doing a little liver biopsy.
Okay, well, maybe I'll touch base with the surgeon and see if he'll just.
Yeah.
While he's in there.
Yeah, while he's in there, just a 2 for 1. Then you'll have no worries. If it's
Right.
if everything looks rock solid, you got a gold standard that says nothing to worry about. So a great job. I think he'll do well. Just keep an eye on that. Ferritin.
Actually, his iron saturation, it was 70. So he might have some.
Hemochromatosis or
Yeah,
something. Yeah.
Can I just say that a gallbladder will not be removed for polyps unless the polyp is 1 centimeter, unless one of the polyps is at least 1 centimeter, unless all these polyps together have given him a dyskinetic gallbladder and its function is less than 30%, then you may have an indication for removal.
Awesome. No, thanks for clarifying. Yeah.
Great. Thank you so much. Really appreciate that. All the comments and the post recommendations. Excellent cases, Robin. Thank you very much. If you have any further questions, let us know and we will get those over to you too later on. All right. Dr. Reed, are you ready to present your two cases?
Yes.
Excellent. I'll go ahead and share your first one. This is 2560.
All right. So my first one is a lady. She's 54 years old. She came to the clinic for a well visit and had some labs done, noticed to have some LFT elevation and some thrombocytopenia. So workup was done and screening for hepatitis C was done after that. She initially declined it, but after that she was okay with it. And it was a new diagnosis found then. I can't really figure out, no real exposures that I can come up with, nothing that she can tell me was for sure her exposure. But she did get a tattoo at a local tattoo shop in 2012. She said she had her ears pierced when she was a kid in an environment in a local shop as well. And then she thinks that maybe when she was working as a server in a local restaurant there, she says she had to clean up some sketchy fluid. She doesn't know exactly what they were. Maybe some vomit, maybe there was some blood, maybe not. She never was provided with gloves during this time. So she thinks maybe that was where her exposure happened. On physical exam, nothing concerning. Her vitals were within normal limits. Other comorbidities, she does smoke tobacco and was prescribed Wellbutrin for smoking cessation purposes. Vaccinations, she is not vaccinated for hepatitis A or B. Her BMI was within normal limits at 23.7. Lab work, her platelets were low at 97. Her creatinine was normal. Her AST and ALT were both elevated at 142 and 107. Her bilirubin looked okay. Her alk phos was 131. APRI was 3.7, CTP of 6, and MELD score of 7. Her ferritin was 249, vitamin D was 30.7, so that's being replaced. HIV was negative. She is genotype 2 and has a viral load of 3 million. Her serum fibrosis marker was F4. And then her Hep B serologies were negative. So I did order a liver ultrasound on her and it was pending last I looked. Let me see if that's still the case. No, it is resulted now. No, they didn't comment on anything in the liver. Increased echogenicity and decreased through transmission consistent with cirrhosis. Her liver ultrasound was consistent with cirrhosis, but no lesions in the liver. They talked about that she does have a polyp in her gallbladder. For her, I was thinking either Mavreat or Palooza. I didn't really know because her insurance is Cigna, so I haven't gone through that process with Cigna yet. So I didn't know if there was any specific recommendations with that. And then because of her F4 and her cirrhosis, HCC screening for her, I believe, moving forward.
Thank you so much. Great job, of course, Dr. Rude. Does anybody have any questions for her?
Just one. So a CBC is sort of what led to her diagnosis. Had she, do we have, or had she ever had past CBCs, or had she just established care with you all?
She just established care with us in September. And her first CBC before that, she had one with platelet count of 82, and then 97 was the one after that.
Are we routinely getting AFPs on the patients, particularly with an F4 or cirrhotic patients? Isn't AFP indicated?
Yeah, in general, we don't, unless there's some ambiguity on imaging, or if the radiologist says they can't visualize stuff very well. You know, if there's anything where they're like, there's something there, you can use it as an adjunct, but it's currently not advocated for routine screening for HCC. That being said, I do check it a fair amount.
Can I also ask if a liver ultrasound is indicated at what point is a liver ultrasound needed? Regarding the degree of cirrhosis, perhaps, or everybody?
Yeah, it's a great question. And if anyone else wants to answer, shush me and I'll happily defer. But the cases where you have any concern for advanced fibrosis. So what would make you worry about such things? Time frame of infection. So if you've had somebody who's definitely had risk factors that have been present for more than 15, 20 years time frame, or if you have any other labs that suggest advanced fibrosis such as APRI or low platelet count or low white count, or any of your hepatic synthetic functions or other things are down. So there's a whole bunch of people it's safe to not do ultrasounds on, and that's your young people with recent acquisition. You're not going to find anything of interest on an ultrasound, but anybody, what you're really looking for is cancer with an ultrasound, and that's only going to happen with hepatitis C after significant fibrosis.
Right.
So you're really safe not doing it on your people without significant fibrosis, but in those where there's at least any clinical concern that it's had a long duration, might have scar tissue, better safe than sorry. The ultimate would be if you could get an ultrasound with a elastography score. That's the best, because it's giving you 2 bits of information. You're getting your HCC screening and you're going to get your really reliable F score with that one. But that's a pipe dream. Hopefully we'll all get that one at some point, but it's useful info. The other reason to do imaging is sometimes it can identify fatty liver and stuff like that. So other diagnoses, and of course they usually spy on the gallbladder as well. And but hope that answered your question. A lot of people it's safe to not order. Dr. Rude did a great job on this one. You got to do it in this scenario. It's a screaming cirrhosis right from the get-go with the platelet count.
Thank you so much. Those are really great questions. Thank you. Appreciate that. And Dr. Gilfus, is there anything else in this case you want to add before we move to the second one?
Yeah, just that CBC of chronic liver disease. It's somehow I got through med school and most of residency without knowing that leukopenia and thrombocytopenia. So it's not uncommon for oncologists, hematologists, to diagnose hepatitis and cirrhosis, and we just haven't seen it lately. So great catch, Dr. Rude. That's awesome. This is not when you want to diagnose somebody, sadly. We wish that she got into care a lot sooner, but now she's cirrhotic and whatever. We got to take care of it. So you are 100% right. She needs HCC screening forever, every 6-month ultrasounds. And I would probably refer her to get an EGD. I didn't hear if you commented, because I was reading the labs. I didn't hear if you mentioned if she had dilated portal vein or anything on the ultrasound, or if they even commented on that.
They did not comment on that.
It's not uncommon for them not to mention it, but if your radiologist, sometimes you can holler at them later and be like, hey, can you give me a measurement on the portal vein? And if it's above, I want to say it's 12 millimeters or something. Anyway, if it's dilated, you have a high chance of portal hypertension, and doing a screening EGDs makes a lot of sense in that scenario. In terms of picking your drug, I can't speak to Cigna or whatever it was. Wow, where do you find patients with private insurance? I'm impressed. That's good. But and with a normal BMI, wow, the rarest of the rare. But you basically, with the genotype 2, have Epclusa or Mavorite to pick from. And when you do have a cirrhotic patient, there is one other decision point, and that's whether or not they're symptomatic or asymptomatic. So remember, if you have a cirrhotic patient with any form of symptoms or anything that suggests risk for decompensation, you want to avoid the protease inhibitor based regimens. You want to avoid things like Vicura, which doesn't exist anymore, and Mavorite, Zepatir, and want to go more with the Harvoni Epclusa when you have a potentially symptomatic cirrhotic. It doesn't sound like this lady has any of that stuff. I don't hear anything about encephalopathy, GI bleeding, ascites, peripheral edema, anything that's freaking me out. She does not have Hep B co-infection, thankfully. So I think you could be fine with either. the Mavorite or Epclusa in this scenario, but just know that in scenarios, if you ever did have somebody who was a child's Pew B or C, you want to avoid those protease inhibitor-based regimens and stick more with your Epclusa or Havoni. But great catch, bummer. And by the way, this sketchy fluids issue. First of all, I hope you get the name of that restaurant so that none of us go there. But hepatitis C can exist on fomites for kind of a disconcerting length of time. Dr. Feinberg has a slide in one of her talks where it says up to 60 days, hepatitis C can hang out in like various bodily fluids on like drug paraphernalia. So Lord knows what she got, what she might have got in contact with, but scary story.
Awesome, thank you.
Thank you so much. Any other comments before we move to the second case? All right, I'll go ahead and share my screen. And there you go.
So the next one is a lady, she's a 64-year-old lady, came into clinic for her annual physical as well and has known chronic hep C, so wanted to talk about options for that. So she says she was diagnosed about 40 years ago. Her husband also had hepatitis C. He was diagnosed in the 70s. She said he was treated in the 80s with interferon and had a terrible experience with that. So that's why she didn't pursue treatment at that time. And she wasn't having any other lab abnormalities or symptoms. So she decided to hold off until new treatments came out. So she did pursue treatment about 10 years ago and was told because she smokes marijuana that she did not qualify for treatment. So kind of has not followed up for it since then, because felt like she still smokes marijuana. So thought that would still be a contraindication for her treatment or exclude her from being able to be treated. Her husband did use injection drugs and she believes that she got it from intercourse with him. She never used drugs herself. Her daughter also has hepatitis C. She thinks that she got it from a blood transfusion because she herself was not diagnosed before she had her daughter. So doesn't think it was vertical transmission, but potentially uncertain. But she did get some transfusions back in the day as well, multiple during one hospitalization in like the 70s. So other comorbidities for her, she has psoriasis and is on Skyrizi. That's kind of a new diagnosis for her and a new treatment course. It is controlling her psoriasis well. She is non-immune to hepatitis A, but is immune to hepatitis B, and her hepatitis B surface antibody was 21. She is obese with a BMI of 42. Otherwise, her labs were pretty unremarkable. Her CBC was normal. Her CMP looked pretty good. Her ALT was slightly elevated at 38 and then 23 most recently. HIV was negative. She's genotype 1A with a viral load of 4 million. Her serum fibrosis marker was F1 to F2. Her Hep B surface antigen was negative, and Hep B core was also negative. I don't think I wrote that on there, but I did test it and it was negative. And then her vitamin D level was low, so I'm replacing that. But for her, she did already have a liver ultrasound done because of her before she saw me, and that was normal as well. But with her serum fibrosis marker being F1, I wasn't super worried about that. So I was thinking of using Mavorite or Epclusa for her. I was thinking Mavorite because she really wants her treatment course to be done by the time she goes on vacation in May. So I was hoping to get her in soon and start that treatment for her because she's really worried about side effects while she's on vacation. And I wondered for her about her interaction with Skyrizi as well, but with that being an immune modulator.
Another great case so much. Thank you so much. Dr. Gilfus, I saw you and you. Go ahead if you have a question.
I was just going to say for Dr. Rushton, this is a case that I would do an ultrasound on, even though you don't necessarily have a bad APRI or anything, just because the duration. We think that our pretest probability that she has some issues with regard to fibrosis has to be high, just given that she's probably had this for 40 years. Now, and remember the natural history of Hep C. It's 1 out of 3 people with it never gets substantial liver damage. She does not appear to be one of those. She's one of the 2/3 that's getting some, but it doesn't look like a lot. So, both her APRI and her serum fibrosis markers suggest just a little bit of fibrosis, F1, F2. So I agree with Dr. Rude, no long-term HCC screening. I'm glad you got an ultrasound. Again, I wish you could get a elastography, but it's not a major, it won't really change anything. I just love more data. Data is a great thing, but it's really cool that she's at F1, F2 after all this time. Do remember that once you begin to get fibrosis and age goes by, you can have nonlinear accelerated fibrosis. So she could go to F3 or F4, even though she's taken 40 years to go to an F1, F2. So treatment options for genotype 1, I agree with you. Mavorite, Repclusa are easy ones. Mavorite, 8 weeks will be done. So a couple cool things on her case. So I'm happy you talked about it. I guarantee that, I actually won't guarantee. I guarantee. I sound like Charles Barkley. So if, can someone do math for me? When would her daughter be born? So she's 64. Do we have any idea how old her daughter is? Is her daughter like 40 or anything? Do we know? There's an estimate.
I think she was born in the 70s because she said the transfusions were like close to birth.
So we're gonna call BS on the concept that mom's blood tests were okay. The reason why is, and this is mother-to-child transmission. The daughter got it from mom, as much as mom doesn't want to say it. The blood test for hepatitis C was not diagnosable until 1989. It wasn't even discovered until 1989. It wasn't diagnosable until 1992. And so 100% the mom did not get prenatal screening for Hep C because it didn't exist. And this represents that 5%. So that's wild. I hope her daughter gets treated. So daughter got Hep C from mom. You don't have to tell the patient that, by the way. That's just, moms have so much guilt to start with, you don't need more guilt on there. So, but anyway, we'll know it. We'll keep it stored in our brains. The other reason I love this case is because of her psoriasis. And that is not an association I know of with hepatitis C, but it is an autoimmune disease. And so as we like to emphasize with the extrahepatic manifestations of hepatitis C is any autoimmune disease may have an association. So I did what I always do in these scenarios, and I go to PubMed and I enter hepatitis C and psoriasis, and lo and behold, there's definitely a relationship. How about this for concrete statement? There's definitely probably a relationship. So in other words, we don't know, but there's at least some autoimmune milieu which can exacerbate psoriasis. Fascinating. Not on my radar, but apparently it can. So your question about the Skyrizi, I'm not worried about it. By the way, everyone can tune out. I have to tell a adorable daughter story. My daughter saw an ad for, every time there's one of these psoriasis commercials on TV, she asked me, she's like, Dad, why do these medicines make you dance? And that's what her interpretation of all these medicines, because they're always showing people dancing and having a great time. She thought that's what the medicines did. So I thought pretty cool. All right, back to the transient daughter story. So anyway, in general, the medicines for rheumatologic disorders are safe for hepatitis C. It's really hepatitis B that might experience some form of flare or exacerbation from most of those autoimmune therapeutics. Hep C doesn't really, we don't have anything that we worry about per se. I did run it through the drug interaction thing, and I didn't find anything either of concern, but big concepts. It's usually Hep B. We were about flaring more than anything else. But good stuff. Treat her. See if her psoriasis gets better, and she's another one that I don't think you need to do anything for long term. But cool. You made me do some learning with the psoriasis. So that's great stuff. And yeah, this is probably our first example of a mother-to-child transmission type of situation. Not the patient, but her daughter.
Mhm.
Excellent. Thank you so much, Dr. Gilfus. And that's adorable about your daughter. Oh my gosh. Is there any other questions, or are there? Sorry. And is there any interactions with the Skyrizi, Rachel?
Nope, it's a monoclonal antibody, so it undergoes proteolytic cleavage. So there's no concern from direct interactions with any of the direct acting antivirals. So you're good to go there. The only other thing
Great.
I guess I'll add is that she has Blue Cross, so she's eligible for copay cards. So don't let financial stuff get in the way of treating her. She should be available for those are available for her.
Great. Thank you so much. Any other questions, Dr. Reed?
The copay card, is there anything specific I would have to do for that, or?
Dependent, so a lot of the pharmacies will, they should attempt to get those. If they do not, she can usually apply for those online through the manufacturer's website. So she is able to do those herself. So if she, if she goes to Maverick.com or Epclusa, whichever one that her insurance ends up preferring, if she has a copay with them, she can go to their website and apply online. And usually they'll, they may ask about income and things like that, but they'll give her the card and she'll just have to make sure she gives that to the pharmacy.
Okay, awesome. Thank you.
And I guess I missed the fact that she was private insurance as well. So a short course of Harvoni, it could possibly be an option for her because she's a viral load less than 6 million in genotype 1A. And so 8 weeks of 1 pill a day with Harvoni is also on the table. So you got Harvoni, Epclusa for 12 weeks or Maverick for 8 weeks. So any of those, depending on our insurance. We never talk about that one because our Medicaid doesn't really have the short course Harvoni as an option, but if she's private insurance, it may be on the table.
Okay.
Awesome. Thank you so much. All right, we'll move on to the didactic. Really appreciate the cases. Again, you guys are rock stars about that. Dr. Gilfus, did you want me to share my screen with the group? Oh, I made you a co-host too, so if you'd want to do it yourself.
Oh yeah, thanks. I'll do it. Thank you.
Dr. Gilfus. Dr. Gilfus, we can't hear you.
Yeah, sorry, I was just messing up.
It's okay.
Everything, we're okay now. We can see the screen and hear me and all that. Okay, and I'm going to apologize ahead of time because I'm gonna probably do this as a 2-part. Is that okay, Elizabeth? If I do this as a 2-part?
Yeah, we'll figure out something. So we'll figure out something. We'll
I have to run the clinic a little bit earlier than usual today. Plus it's too big of a topic. And I hate to do it injustice by rushing, but we'll talk about hepatitis B a little bit. This is it commingles with hepatitis C, similar transmission mechanisms and similar population infected. And so we have to have familiarity with it. I know we tend to obsess about the hepatitis B, hepatitis C interaction with each other, but this is just going to be giving hepatitis B its own glory so that we have a little bit of knowledge about it. Feel free and honestly interrupt me, ask questions. I want it to be helpful and useful. What do we know here? So look at this. It's discovered a decade and a half before hepatitis C. We just mentioned that last case. Hepatitis C was described in 1989. And, hepatitis B was a known phenomenon a lot longer than that. It's also different from our RNA-based hepatitis C that we're used to talking about. And it's a DNA virus. And why that matters, probably more than anything, is that we don't talk about curing hepatitis B, which is awful. And the reason why, we don't really understand what hepatitis B does. It does form what is described as mini chromosomes. So we can't really clear it. It almost becomes an extra. So we have an extra chromosome in our infected cells that doesn't go away. It also does directly integrate into our genome, being a DNA virus, but it doesn't seem like it produces virions from that, but it might be pro-oncogenic after it inserts. So anyway, interesting. Just a couple of things about the virus itself. It's we know it makes the surface antigen. That's part of its glycoprotein capsule. Okay. A couple of the proteins just to know. It has the core protein. The core protein or antigen, same word, is not secreted into the blood. So it's one that the liver is the only place it's going to be is in the hepatocyte. So hepatitis B makes the core protein and it hangs out just locally. You can't find it in the blood. There's another gene product called the precore. I wish it wasn't called the precore. It's confusing. There's no reason. I wish they would just call it the E protein, but for some reason it's not. And the reason I'm mentioning it is not to confuse you. It's so that if you ever read about hepatitis B, you're not confused yourselves, because I was very confused when I was reading all about this precore. All it is it's the gene that codes for E. The gene that codes for E, okay? So you might read about precore mutant hepatitis B virus. What does that mean? It means hepatitis B virus that doesn't make the E antigen. And they exist. And so how would you ever know your patient had that? Well, they would be E antibody and E antigen negative, yet they'd still have a surface antigen and DNA that's positive. Does that matter? Yes, you still have to worry about those patients. You have to treat them. So I'm purely clarifying a terminology that is confusing, okay? And hopefully not confusing you by talking about it. Okay, those are the major proteins you have to know. There is another protein called the X protein. This is the scary one. This is an oncogene. So, you know, why is hepatitis B so much better than hepatitis C at causing cancer? Because it actually carries a gene with it that's an oncogene that directly has a causal role in hepatocellular carcinoma. So remember, unlike hepatitis C, that has to progress to cancer through scar tissue and inflammation and time and all this other whatnot, hepatitis B can progress straight to cancer after a much shorter time period and without cirrhosis. Kind of scary. But it's why you'll see recommendations for doing HCC screening in your hepatitis B patients much, much earlier on than you see for patients who just have hep C. Okay. Now, this other thing, one of the other genes codes for a polymerase that is pretty unique. Remember, this is a DNA virus. So how does DNA copy itself? It normally copies DNA to DNA. When you want to have a gene product, you copy DNA to RNA that then is translated into a protein. So that's sort of the, you know, the ladder of life. But this weird virus decides to copy its DNA into RNA intermediate and then back to DNA. Now, is this purely curiosity? Yes, but for any of you pharmacologic nerds like me, that's also awesome. And the why is because we have a lot of drugs that know how to interfere with RNA-dependent DNA polymerases, all of our HIV drugs. So due to this quirk of nature, even though this is not a retrovirus, because Hep B copies itself through an RNA intermediate, we can use antiretrovirals to treat Hep B, at least the ones that act on reverse transcriptase. So that's pretty awesome. It always perplexed me. I was like, how on earth does lamivudine or how does tenofovir work for Hep B? It's not a retrovirus. Well, that's the why. Okay, might be more than you want, but man, it's good stuff. Now, what about transmission? You know, the transmission stuff, what it does way better than hepatitis C is sexual transmission and mother to child transmission. It's way better at it. So whereas we say that hepatitis C is very non-effectively transmitted sexually outside of HIV positive men who have sex with men, with Hep B, sexual transmission is real common. What else is super common is mother to child transmission. You know, parenteral transmission can absolutely occur. It tends to be one of the predominant mechanisms of transmission we see in West Virginia, but worldwide, it's not. And I just misspelled this word, sorry. Can remain infectoid for 7 days outside the body. So infectious, I think I was trying to say, for 7 days outside the body. So not quite as impressive as hepatitis C with the potential many, many weeks outside the body, but it still can hang around a little while. And like every viral hepatitis, there's a fairly long incubation period. I don't know any of the viral hepatitis that have a several day incubation. Most of these have have weeks to months for incubation period after exposure before you get symptoms. Okay, fascinating stuff. Epidemiologically, there's probably about the same number of people who have Hep B that have HIV in the United States, somewhere around 1 million to 1.5 million people. There's about the same number of new cases each year as we see for hepatitis C. So somewhere around 20,000 new cases a year. Most of those are unrecognized. Okay. And this is this is a sobering statistic. So 15 to 25% who become chronic carriers die prematurely. So wow, that's impressive. It's actually worse than hepatitis C. So remember the statistics on hepatitis C in terms of morbidity associated. Usually it's in the realm of about 5% downstream get cirrhosis or cancer, or get die of their cirrhosis or cancer, whereas it's a little higher for chronic Hep B. There's good news I'm going to get to though, and I talked about this already. In the U.S., it's sexual activity, injection drug use, and then even healthcare work, so occupational exposure risks. I'm sure y'all are sick of seeing these slides that show West Virginia as being a standout, especially the southern part of the state. But just as it is for HIV hotbed and Hep C hotbed, we see it for Hep B as well. And sort of bucking the national trend, West Virginia and the Appalachian area is heading upwards rather than down. Internationally, this is the fascinating part about hepatitis B and where it is infinitely more successful than hepatitis C. The most frightening statistic I saw was about 1/3 of the population at some point in their lives is exposed to hepatitis B. So it sounds like a beautiful disease process to vaccinate everyone from, which, we're getting there. The kids born nowadays get their Hep B vaccinations, but there's a whole lot of catch up that needs to be done. And then about 350 have chronic infection. And that leads to just the sheer numbers lead to a lot of death and morbidity related to hepatitis B. And I was kind of shocked. And the most recent statistic I saw was 2017. It was the 7th highest cause of death in the world. So kind of awful. And how people die, again, is cancer. Cancer and cirrhosis is what it does. So, and yeah, some areas of the world, it's incredibly endemic. So, and really the mechanism of transmission tends to correlate with the endemicity. And that makes sense if you think about it. In low endemic areas, it tends to be sexual transmission and injection drug use, adult to adult. Whereas in high endemic areas, it tends to be mother to child, i.e. vertical transmission. And here's just a graph that shows you basically everywhere in red is high risk of vertical transmission. In my clinic, I see a whole bunch of people from Southeast Asia, Africa, who emigrated to the United States, got their hepatitis B testing, and find that they have hepatitis B without ever having known it. And again, they're a lot of times stigmatized themselves, I should say, because they sort of associate this with drug use or high risk sexual behavior, and it's not. This is something they were born with. This was literally something they were born with because of the endemicity of where they were born. Fascinating stuff, but the numbers are just mind blowing. So what does it do to you? It really matters when you're exposed. So hepatitis B can cause both acute and chronic, obviously, liver disease. And the age at which you're exposed determines your likelihood of either clearing the infection, A, or B, how symptomatic you get. And so it's a paradox there. If you're exposed early on, you have a very high likelihood of developing chronic disease, but having no symptoms. Whereas if you're exposed as an adult, you have a high likelihood of developing symptomatic disease, but a low likelihood of it becoming chronic. So I guess if you had to choose when to be exposed, you'd want to be exposed as a healthy adult, or better yet, not at all. You want to be exposed after a vaccine, then you're good. But it's just one of those things. And it really, this slide, it says the correlate of this. So this talks about the likelihood of progression to chronic infection. And this next slide talks about your likelihood of actually having clinical manifestations. So again, most kids, most of these people born in endemic areas do not carry with them any history of an acute hepatitis, a jaundiced episode, or any issues with LFT abnormalities. It's almost like they're exposed so early that their immune system just habituates or has no real reaction to the virus. That just becomes part of their mini chromosome with Hep B on it. Whereas as an adult, it incites a much more significant inflammatory response correlating with symptomatic disease. And what does it do when you're symptomatic? Really, it can do anything from asymptomatic, so subclinical, to an acute hepatitis, and I'll kind of describe what that looks like, to straight up causing liver failure, and then obviously the dread complications of any chronic viral hepatitis being cirrhosis and cancer. And then look at that increased fold risk with chronic HBV. You know, it's that darn X protein. It's the fact that the virus itself carries with it an oncogene that's going to really explode the risk of HCC with Hep B relative to basically any other form of chronic liver damage. So what does acute Hep B look like? Honestly, acute Hep B looks like any other acute hepatitis. You can't tell them apart from a clinical presentation. I don't care if it's Hep A, B, C, E, or a D superinfection, or a not from one of the viral hepatitis. If it's an acute hepatitis from herpes, or it's acute hepatitis from Coxsackie virus, or something else. You know, any other of the causes of viral hepatitis clinically present the same, and they present as a GI non-specific illness. So sort of you lose your appetite, you might have some constant nausea and vomiting. Sounds horrible. Feel achy and yucky all over because your cytokines are going wild. That's your arthralgias, myalgias, headaches, etc. This one I never would have guessed that it could give you URI symptoms. That's kind of concerning. And it's usually not until you have dark urine or clay-colored stools that anyone's really going to focus in on your liver just clinically. So, yeah. Fulminant hepatitis, I've never actually seen it from Hep B, thankfully. But you can present like any other liver failure patient. And that's basically, you know, they look yellow, they're getting encephalopathic, coagulopathic, and you might have other organ systems fail as well. Awful situation. Get those patients to a transplant center ASAP. Now, remember with hepatitis C, some of my favorite things to talk about are the extrahepatic manifestations. It is mirrored nearly identically with hepatitis B. Again, mechanistically, if you think of the extrahepatic manifestations for Hep C, they tend to mostly come from the chronic inflammation and the inadvertent immune response, the unintended generation of autoantibodies, the overall inflammatory milieu. Same thing for Hep B. So as such, what you do see is the same stuff. You see arthritis and arthralgias. You see immune complex disease in the kidneys. You can see vasculitis. Now, the vasculitis that tends to run with Hep C is cryoglobulin vasculitis. The hepatitis B vasculitis tends to be PAN, polyarteritis nodosum, so more of a medium vessel vasculitis. But it can get anything. You can see, you know, any form of vasculitis from it. Tends to have, I think of this one in my mind as having more potential to cause neurologic complications as well, such as you can see the spinal cord and peripheral neuropathy as well. But anyway, just keep in your mind, it's a whole body disease. Man, is it a whole body disease. I didn't have it on here, but the viral loads that you see with hepatitis B are logarithmically higher than any other infection. Very common viral loads for hepatitis B are in the hundreds of millions, as opposed to maybe 1 million or so for Hep C and 100,000 for HIV. So you can imagine that it's a very pro-inflammatory stimulus. Oopsie. So during the acute hepatitis, you can see viral loads super high, up to a couple thousands, and so on and so forth. The INR, the coagulopathy, is again the best indicator of prognosis. And this would be a bad time to check alpha fetoprotein. You would definitely want to check that during acute viral hepatitis. You would misdiagnose somebody as having a hepatocellular carcinoma, possibly, or a pregnancy, one of those two. Now,
Dr. Gilfus,
yeah.
I apologize. If it's okay, can we stop here for the first portion?
Yes, this is actually where I stopped last time.
That's hilarious.
Yeah, it's perfect.
So that we have a question. Robin, go ahead and expand on that if you'd like.
Yes, sorry, I just wanted to just see if I'm doing this right.
Yeah.
I reached out to a friend of mine who's a GI provider, and they said if I have a positive hepatitis B, and the reason this came about was because I sent a hepatitis B patient to them. But they did a viral load on him, a hepatitis B viral load, and it was negative. So then they vaccinated him. So that since then, that's what I've been doing. I want to make sure that's the recommendations that you have. If when I get a positive hepatitis B, and I actually see quite a few core positives with a non-reactive antibody. I see that quite a bit where I work. I see a lot of substance abuse patients here. So those patients, what I've been doing is checking a viral load, and if it is negative or not detected, then I go ahead and vaccinate. Is that what I probably should do for my hepatitis C patients? Did that make any sense?
Dr. Gulfos?
Oh, man. Yeah, no, I just was having serious techno brain shortage. I was trying to figure out if I was still sharing my screen. Yeah, no, I disagree with the GI doc. I wouldn't do that. Hepatitis B vaccines, first of all, they don't hurt. They don't hurt you. You're just giving somebody surface antigen. And I've never seen anybody have a problem with it. And I might have told you this before. We once had a patient who got we literally, this was not on purpose. They would just traveled a lot to other healthcare centers. They had received 12 series of hepatitis B vaccine. So, and they weren't suffering from any negative, problem. So do you have to do it? The answer is here. I'm gonna share my screen again, and then look at this. I think I have the answer to it. Here we go. Yeah, right here. So it's going to be. This is going to be one of the answers to the part of the second talk. But what do you do if your patient has isolated core antibody? So that is true exposure. The answer is it could be any of these things. And for most situations, it does not. You don't need to bother revaccinating. It's only basically false positives that you'd expect you'd have to revaccinate people for. Everything else, or this, you don't. We're just comforting ourselves. You don't have to do it. If you're isolated core positive with a negative surface antigen and negative surface antibody, you want to make sure you're getting your these studies. So get your e antigen and your DNA PCR, and of course a hepatitis C study. I'm sure you've already done those, but based upon those, you can actually decide whether or not you want to vaccinate people. Most of them don't need to be vaccinated.
Okay.
But
Do you think they will develop immunity, or I mean, how do I? There's no way for me to prevent them from developing into a chronic disease if their viral load is not detectable, or do you think they will develop antibodies later?
What probably happened in most situations, it's just that it was so remote that they've had a decay of their surface antibody to the level of being undetectable. So most of these are patients that are this number 3 on here, resolved hepatitis B. Oops, crapola, I stopped sharing my screen again. So resolved hepatitis B infection with waning titers of surface antigen. No, I'm sorry, surface antibody. So that's the majority of these people. Other than Hep C co-infection. Those are kind of the two that you most often will be seeing, and neither of which giving a vaccine is going to hurt or help. If you checked again after a single booster and they're already their titer went from nothing to sky high, it's probably 3. It's probably number 3 up here. I hope that made sense. That makes sense. And I'm going to go over that in detail, by the way, next half.
Okay.
Yeah. So great question on our agenda.
Excellent. Absolutely. So we'll get those slides to you, everybody. We'll finish this off. So when you're looking at them, just, maybe look ahead and get some questions in mind for the end of the session next time. So we really appreciate everyone's time today. And our next session will be on March 24th. Bye-bye.
Thanks, everyone.